So next is acute upper limb ischemia. It's V6. A 72-year-old male presents with 2-hour history of sudden onset right arm coldness, paresthesia, pallor, and pain. He can just move his fingers and forearms. Muscles were normal. He is known to have atrial fibrillation on warfarin, but his INR today was 1.3. There was no other significant history of note. On examination, the right hand was pale and the right brachial pulse absent. All pulses were palpable in the other arm. What is the diagnosis and differential diagnosis? The diagnosis is acute limb ischemia due to the emboli. There is sudden compromise of the blood flow to the limb and threatening its viability. Treatment should be prompt to avoid irreversible damage. After 3 to 6 months, muscle and nerves may suffer irreversible damage, and very delayed treatment may cause the Walkman's ischemic contracture. A differential diagnosis includes the aortic dissection and cervical rib, causing the thoracic outlet syndrome. Usually, it's a chronic. Previous claudication or involvement. Who would investigate this patient? So all baseline investigation: CBC, coagulation, ECG, chest X-ray, CK. Cardiac enzymes 20, and later we will do heart echocardiogram and 24-hour Holter tape. While waiting in the operating theatre for emergency brachial embolectomy, brachial artery imaging with bedside duplex ultrasound with experienced vascular sonographer surgeon to determine the extent and level of arterial occlusion, presence or absence of the collaterals, ulnar radial arteries, and mark the brachial artery at the elbow. Describe your surgical approach. The brachial artery can be explored in the general local anesthesia. Brachial and renal arteries can be exposed through the S-shaped incision in the antecubital fossa. The biceps tendon is the most lateral. And brachial artery is in the middle, and median nerve is in the medial. So it's MBB. The brachial artery is covered with a trapezius membrane which needs to be divided. After giving systemic hypertrophic clamps are applied to the brachial artery and transverse arteriotomy is made in the distal brachial artery. A Fogarty catheter, French 2 French to 4 French catheter is passed cranially and distally in all the vessels to clear the clots, and all the arteries are flushed with hypertenous saline. The artery is closed with 6-oproline. Are there any other treatment options? Thrombolysis, but the risk of distal embolization. There is also risk of systemic hemorrhage, 1%. Probably open embolectomy is a safer option for this patient. For lower limb acute emboli, the STYLE trial and the TOPAZ trial have shown that thrombolysis have similar limb salvage rates as surgical embolectomy. Other endovascular treatment options not suitable here. The cardiologist prescribed new oral anticoagulant for this patient after surgery. What is your understanding of the new oral anticoagulants? These new oral anticoagulants include the dabigatran, Pradaxa, made in Germany, and rivaroxaban, again Xarelto, made in Germany, and then apixaban, made in USA, and edoxaban in Japan. These all are non-vitamin K antagonists. They have emerged as the preferred choice, particularly in patients with newly started anticoagulant, prevention of systemic embolization, prevention in atrial fibrillation, and for treatment of venous thromboembolism. Unlike warfarin, new oral anticoagulants have predictable pharmacokinetics, fewer drug interactions, shorter half-lives, and quicker onset of action. They do not require frequent laboratory monitoring, but there is a lack of validated reversal strategies. So new oral anticoagulants are classified into the 2 groups. One is direct thrombin inhibitor, which is dabigatran, and one other are the factor 10A inhibitors, which the factor 10A catalyzes the conversion of prothrombin to thrombin. So dabigatran directly acts on the thrombin, and other act as a stop the enzyme which converts prothrombin to thrombin. All neural anticoagulants exert an antithrombotic effect, and ideally they should be stopped 18 to 48 hours before elective surgery and resumed 6 to 7 hours postoperatively. As all new anticoagulants had short lives, it is recommended to delay and life-threatening surgery until the effects have worn off. Thank you.